diseases. And introduction, non-arthromatous causes are considered to be a rare cause of critical ischemias. Usually, it is seen in the young patients with no risk factors for atherosclerosis. The two most common causes of non-arthromatous occlusions are popliteal artery entrapment syndrome and adventitial cystic disease. Popliteal artery entrapment syndrome, it has been found in the postmortem studies with an incidence of 3.5%, and 60% of young individuals with claudication will suffer from this syndrome. Predominance of male is seen, and the mean age of presentation is 32 years. And in 30% of the cases, it is seen in both sides. And then 2/3 of patients with unilateral symptoms were found to have bilateral anatomical abnormality. And to understand the popliteal artery entrapment syndrome, it is important to know the development of the lower limb arterial system, which comes predominantly from the external artery and the axial artery, which is the sciatic artery shown in this picture. The femoral artery. So can you hear me, sir?
Yeah.
Sir. The femoral artery continues in the anterior compartment, and the axial artery continues in the posterior compartment of the leg of the thigh, and it forms the popliteal artery. With relation to the popliteus muscle, it forms the proximal popliteal artery, which is proximal to the popliteus and deep to the popliteus muscle, and distal to the popliteus muscle. That is the deep popliteal artery. And at 42 days of gestation, what happens is that the femoral artery in the anterior compartment forms a communication with the proximal popliteal artery of the axial artery. And subsequently, another branch forms which connects the proximal popliteal artery and the distal popliteal artery, which superficial to the popliteus muscle. And over a period of time, the part of the popliteal artery which is present behind the popliteus muscle will egress, and the final mature popliteal artery is formed. The development of gastrocnemius muscle also to be noted. Initially, both the heads of the gastrocnemius muscle originate from the proximal tibia and they migrate cranially. The final position of the medial head is more proximal than the lateral head, and with the popliteal artery lying immediately lateral to it. Classification of the entrapment syndrome is divided into 6 types based on the relationship of the popliteal artery and the middle head of gastrocnemius. And in type 1, the popliteal artery is formed before the medial deviation of the gastrocnemius muscle. So the gastrocnemius muscle, middle head of gastrocnemius muscle, which moves more medially, pushes the popliteal artery towards the medial side. That causes the popliteal artery deviates more medially to a normally situated gastrocnemius muscle. Type 2 is similar to type 1, but the gastrocnemius muscle will have an abnormal attachment to the lateral aspect of the medial femoral condyle or the intercondylar area. In type 3, an abnormal muscle or slip or a fibrous band arises from either the medial or lateral femoral condyle. In type 4, the presence of the axial artery, which was present deep to the popliteus muscle, will not egress, and that will persist at the mature popliteal artery. Thereby, the popliteus muscle will encase the mid-popliteal artery, and that will cause the entrapment. In type 5, in any of the cases, whenever the popliteal artery and vein is also involved, that will come under type 5. And type 6 is functional, and with popliteal artery entrapment will be seen, but no abnormality will be found. But it has been found that the lateral attachment of the medial head of gastrocnemius to the posterior aspect of the medial femoral condyle is the inciting factor. So in this picture, we can see in type 1, the popliteal artery is more deviated more medially, but whereas the medial head of gastrocnemius is attached in normal position. Whereas in type 2, similar to type 1, but the medial head of gastrocnemius will be attached to the more laterally. And in type 3, a small slip of accessory slip of gastrocnemius muscle will come and encase the popliteal artery. And in type 4, the mature popliteal artery will be present behind the popliteus muscle. Type 5 is addition of popliteal vein compression also adds to the type 5. Type 6 is functional. Pathology. This popliteal artery entrapment will cause chronic popliteal compression, which can form fibrosis of the various arterial levels, to complete occlusion and also thrombosis of the artery. In stage 1, the fibrosis is confined only to the adventitia. In stage 2, it extends into the media and may result in post-stenotic dilatation or aneurysm formation. In type 3, the artery may become completely thrombosed. Clinical presentation, it is this invariably seen in young active male with history of claudication, usually an athlete, who will complain of claudication pain, which will be atypical or paradoxical, which will worsen with standing or walking and with improving with vigorous exercise. And in case of venous entrapment, cough, cramping, or compartment syndrome like symptoms can also be seen. On clinical examination, the pedal pulses at rest will be palpable normally, but whereas when the patient is subjected to active plantar flexion or passive dorsiflexion, the pulsation will either reduce or completely disappear. This is because this maneuver puts the gastrocnemius muscle into contraction, thereby compressing the popliteal artery, and that will result in disappearance or reduction in the pulsation of the pedal pulses. So, based on the clinical classification, clinical presentation, it is classified into 6 classes. Class 0 being asymptomatic, class 1 being pain, paresthesia, and cold feet after physical training, and class 2 being claudication while walking of more than 100 meters. Class 3 is less than 100 meters. Class 4 is rest pain, and class 5 being necrosis. And once the clinical suspicion of popliteal entrapment syndrome is made, and patient has to be investigated initially by non-invasive testing. First will be a treadmill test, wherein the resting ABI will be measured, and the patient is subjected to treadmill testing. And post the treadmill test, ABI should be measured, and this will and significant reduction in the ABI will objectively prove the presence of arterial insufficiency in those patients. And the Doppler pressures in the posterior tibial artery should be measured first at rest and also and during active plantar flexion active plantar flexion and passive dorsiflexion. And pressure difference will be seen while doing the compression maneuvers. This will document the presence of compression of the popliteal artery. And duplex should be done, which will duplex visualization of the popliteal artery during the muscle contraction relaxation should be done, which will show the more inward displacement of the popliteal artery during the contraction maneuvers, and also the peak systolic velocity will be more increased during the contraction maneuvers. The positive duplicate test should prompt further imaging evaluation, and the DSA is the gold standard, and it should be obtained in neutral and with the provocative maneuvers. It can delineate the tibial anatomy also. And out of the 3 criteria, 2 has to be present for the diagnosis of popliteal entrapment syndrome. One is the medial deviation of the proximal popliteal artery. Second is focal occlusion of the mid popliteal artery. Finally, the post-stenotic dilatation of the distal popliteal artery. So here you can see in the first picture, there is medial deviation of the popliteal artery with mild focal post-stenotic dilatation. And in second picture, the focal occlusion at the mid popliteal artery level. CT angiogram and MR angiogram can also be done, which is but the disadvantage being this cannot be done with the as a dynamic method, you cannot image during the contraction maneuvers, and it is basically done to find out the other cause, to rule out the other causes of popliteal entrapment syndrome or popliteal diseases like popliteal aneurysm or adventitial cystic diseases out. Once the diagnosis is made, and the treatment mainly depends on the status of the artery, whether it is normal or abnormal. Abnormal being either occluded, stenosed, or post-stenotic dilatation, or it is aneurysmic. If the status of the artery is normal, for main treatment will be the myotomy, division of the medial head of gastrocnemius muscle or the tendon, which causes the compression of the popliteal artery, and repositioning of the popliteal artery into the normal position. In entrapment types 1 and 2, myotomy is a treatment of choice, and surgical approach will be more medial. And in type 3 and type 4, surgical approach will be posterior, because the abnormal muscle slip or the popliteus muscle has to be divided, which can be more easily done in the posterior approach. And in type 5 myotomy, it can be done either medial or posterior approach. And type 6 is myotomy, it should be done only if symptomatic. And if the artery is abnormal, that is occluded or stenosed or aneurysmal, in addition to the myotomy, should be proceeded by the arterial resection and placement of the exclusion bypass, either with the vein or the conduit or the prosthetic bypass. This can be done usually in the posterior approach. Intraoperative findings for proceeding with bypass will be peak systolic velocity of 250 to 275 cm per second, velocity ratio of more than or equal to 2, presence of arterial occlusion or presence of aneurysmal degeneration. In case of type 6, which is considered to be functional, when the patient should be treated when the patient is symptomatic, and initially botulinum toxin injection into the middle head of gastrocnemius can be done. This will cause the relaxation of the muscle, and this can also cause atrophy of the muscle, thereby the popliteal artery can be relieved of its compression. And in severe cases, surgical resection of the muscular portion of the medial head of gastrocnemius with preservation of the tendon should be done. And complete resection of the muscle fibers from the posterior aspect of the lateral femoral condyle and the intercondylar area also should be done. And adequacy of muscular resection can be determined by intraoperative duplex finding. Then posterior approach, a LACS incision is made and the deep fascia is open. The tibial nerve popliteal vein is lateralized. Lateralized, and the popliteal artery will be found more in the more proximal part of the incision, and the compressing part of the middle head of gastrocnemius should be divided, either the tendon part or the muscular part, whichever part is compressing the artery, and based on the status of the artery, whether myotomy is enough or it should be proceeded with arterial reconstruction should be made. Decision should be made according to the condition of the artery. Summarize the popliteal entrapment syndrome. First, the clinical features suggestive of entrapment syndrome. If it is present, clinical provocative test should be performed, and if it is positive, Doppler ultrasound should be done, and it should be further confirmed by either DSA or CT or MRI. And if it is an anatomical occlusion, and it should be proceeded by surgical decompression. And if it is a normal anatomy, functional popliteal entrapment syndrome, and consider trial ultrasound guided Botox injection at the site of occlusion, or if it is present, surgical decompression of the middle head of gastrocnemius should be done. The next entity is adventitial cystic disease, which accounts for 0.1% of the claudication population, which usually unilateral with a male predominance. The arteries most commonly involved are popliteal artery, external iliac followed by external iliac, and the femoral arteries. Venous system involvement can also be seen, but it is rare. There are various etiologies which are attributing to the adventitious cystic disease. First is the repetitive trauma theory, which suggests that the repeated flexion and extension of the knee joint causes chronic injury of the popliteal artery with cystic degeneration that will result in the adventitious cystic disease. And in the ganglion theory, the presence of either a Baker's cyst or a simple ganglion in the popliteal region will spread to the branches of the popliteal artery, and that will cause cystic disease. And in systemic disorder, either a systemic mucinous or myxomatous degenerative condition leads to the development of ACD. In developmental theory, during the development, the mesenchymal cells that forms the joints can be incorporated into the closely adjacent vessels, and these may be responsible for subsequent cyst formation. And when these mesenchymal cells start to secrete mucoid material, that will form the cystic disease of the popliteal artery. In articular theory, synovial fluid from a neighboring joint egresses and dissects along the adventitia of an articular branch to the parent vessel, thereby forming the cystic disease. In pathology-wise, and grossly popliteal artery will appear enlarged and sausage-like with dense additions to the adjacent structures. And microscopically, simple cuboidal cell lining in the adventitial layer will be seen. During surgery, cyst can be seen cyst can be seen following incision of the adventitial layer. Clinical presentation, similar to popliteal entrapment syndrome, there will be a history of claudication in a young patient. The claudication will be a sudden onset of short distance claudication, and typically the recovery time is usually prolonged up to 20 minutes. Most present with popliteal artery stenosis rather than occlusion. And in these cases also, pedal pulses will be normal at rest, but disappear with the flexion of the hip and knee, where the joint space is put into contraction. That will cause compression of compression of the popliteal artery, and by the pedal pulses will become absent. This is known as the Ishikawa sign. And in venous adventitious cystic disease, most commonly involve the iliofemoral segment, and it will cause a painless swelling of the lower extremity. Extensive compression on venous duplex imaging or a filling defect in venography will be seen. Investigations wise, duplex should be done, which will show the location and number of cysts, and also the presence of any compression of the popliteal artery, and the peak systolic velocities might also be elevated in case of compression stenosis of the popliteal artery. Angiography should be done, which will show eccentric compression of the popliteal artery lumen. A Schmitter sign, which is a thin rim of contrast in the over the affected area, and hourglass sign when the popliteal artery is encased on both sides by the cystic disease. That will cause the hourglass sign. Both the anterior, posterior, and lateral views should be taken. This is an example of hourglass sign and the Schmitter sign. MRI should be done. To MRI and CT angiography, CT angiogram should be done to know the extent of the disease and also to know the involvement of the adjacent structures and to rule out the other causes of like popliteal artery aneurysms can also be ruled out with the CT and MRI. Management depends on management comprises non-resectional intervention or resectional intervention. Non-resectional interventions include transluminal angioplasty, which is of the affected segment, which is usually ineffective, which will recoil within 24 hours. Usually not done. The cyst aspiration, CT or ultrasound guided aspiration of the cyst can be done. Recurrence will definitely happen with this method of treatment. Should be done only to patients who refuse surgical treatment. And cyst excision and evacuation should be done. That will also cause recurrence in some cases. Resectional intervention, in case of popliteal artery thrombosis or extensive arterial degeneration, excision of the affected arterial segment followed by bypass with the autologous conduit should be done, usually by a posterior approach. The picture showing the adventitial cystic disease, wherein the artery is completely removed and replaced with the bypass graft. Thank you.